Mohan Rajakaruna, and we have my chairpersons are Dr. Disna Amaratunga and Tanya Pereira and Dr. Vasanta Kapuatta. We have an interesting symposium today. We're going to talk about how to optimize the PCI outcomes. We have three eminent interventional cardiologists who are going to talk about this in different subjects. Without further delay, I would like to introduce you our first speaker. He is Professor Robert Jan Funguns, Professor of Interventional Cardiology, Redbound University, the Netherlands. He is going to talk about the anatomical assessment of a coronary lesion. Over to you, Professor.
Thank you. Good afternoon. I hope that they can share my desktop computer, which is ready to show my slides. The audio should be from my iPhone. That looks better. Okay, I think the audio is okay and the slides are okay. And you asked me to talk 20 minutes about anatomy. And what do we know from anatomy in these current days where we have so much function? And I have seen that Justin Davis is going to talk more on function afterwards. So I think I'll just go ahead with my presentation. I think he has a lot to comment on it later on or to add. I hope he's a bit friendly for me. The anatomical assessment of the coronary lesion. I changed the title in, why is anatomy important? Because there's more than function, as we'll see later on. Or what can we achieve without a pressure wire? And I try to copy that, discuss that in the next 20 minutes. And for that we will focus both in ACS and stable angina patients with culprit lesions, non-culprit lesions, patients without any lesions, and high-resolution imaging, and extended options of anatomy. So let me first start with the patient who we treated 2 years ago. I think he is at that moment 50 years old, no risk factors, presenting with chest pain on a pre-hospital ECG head and STEMI, coming to the hospital, arriving to our cath lab, the ECG normalized, still due to the transient elevation, so he was in the cath lab. You can see there is something abnormal, but we don't know exactly what's abnormal in there. You have the arrows in there. I zoom in a bit. It's a bit hazy, but still a bit unclear. So we decided to do the OCT imaging, giving us additional anatomical information for this patient. And you can recognize, I think, the OCT images where we see a nice continuous vessel structure with all signs of red thrombus dropping off the signal. And if you look at the longitudinal reconstructed images, you can also see the intact vessel wall and the thrombus, which is usually at several locations on top of it. And we couldn't identify a plaque rupture in that moment. So if we look in the past few years of OCT imaging, we have learned that we now ACS patients, even in the STEMI patients, we can see ruptured plaque, erosions without rupture, but thrombus on top of it, or calcified nodules which are protruding into the lumen, which have all been identified as potential reasons to have an ACS with a thrombus. Now, I just want to draw your attention to this nice series of manuscripts, publications in the JACC this year. One on plaque erosion, and they did do a nice classification, the definite erosion, where through the thrombus you can see that there is no plaque rupture. Probably erosion where no plaque rupture was identified, and a lot of local red thrombus is identified, but still no plaque rupture, or the true plaque rupture with an opening and a thrombus on that. Now, if you want to see the diagnostic screen schedule for that, so if you do the OCT, you can find a disrupted plaque or an intact fibrous cap plaque. And that's what I just showed you. You have either the definite plaque erosion or probably plaque erosion. If you cannot see the underlying plaque, but you see thrombus with an irregular surface. Within the ruptured plaque, you can see just a lipid pool or an underlying plaque with calcium protruding, and then we come up with the diagnosis of the calcified nodule. So I think the anatomy is here leading in what is the mechanism of your ACS, and potentially also give you some different options to treat for the patient. Now, how frequently is that plaque erosion? They also, in this publication of this year, they summarize it very nicely. And if you look at with the OCT, which is over 1,000 patients, 800 in one series, 1,000 patients in the other series, it's all about 30 to 40% are not true plaque ruptures, but were classified as plaque erosions. So it's a really, really frequently presentation. And then also they did work on a prediction model. The younger the patient, there is less probability of plaque erosion, but more plaque ruptures. If you have a combination of young age, anterior ischemia, no diabetes, a normal renal function, they found up to 70% of patients having plaque erosions. That's the publication by Jan Hoto, who is then copied to the recent publication in the JACC. So, because if you have the STEMI or the non-STEMI, you can see that if you have identify a plaque erosion, and we'll come back to that later, you could really consider that if there's no significant lesion, and the question is also significant lesion, but if there's a small lesion anyhow, you could also do only antithrombotic therapy without stenting, because the plaque erosion is pretty high, or you identify it's only OCT. I just wanted to show you a few images. Of course, this is one patient we had recently in our hospital. We do a lot of patients where we see non-obstructive coronary artery disease, normal angiography, some troponin markers, but we don't understand where the culprit lesion is at all. Now, this is a nice example of the SCAT identified with the OCT, the true lumen, the false lumen. I think you have seen that before. Jackie Shaw published that in 2017 with the type 1, 2, and 3, where you can see the multiple radiolucent lumen or just a long and smooth narrowing. And I think this is one of the types where sometimes OCT is helping us to understand the difference between an obstructive plaque, lipid-rich plaque, versus an hematoma of the SCAT, or even the focal tubular stenosis. Some examples. This is the multiple lumens. You know that from the past. This is the one with long diffuse comparison. Now, that's another same image. I won't complete that. But if you do the OCT for these kinds of patients, you can see the real difference. Sometimes even with some dissection, with some thrombus being present due to the SCAT. But these are the most frequently where you see some vessel wall and then a large hematoma beyond. With low flow, if there's hardly any flow, you see it pretty much reflection, but the more contrast is able to get into the dissection lumina, the more you see it as a cleared out black lumen. So I think that's talking to you about erosion and being possible to be identified just on anatomy. It's really important things because it might change your treatment strategy. But over the recent years, we can also see that anatomy, based on the OCT, and is predictive to make decisions on PCI or not. Of course, we have to have some identification. We worked on NICE review, which has just now been in press. But then, of course, you look at the reference area, the MLA, the MLD of this lesion based on the OCT, which is much more accurate than on the QCA, and then distal reference area. Now, if you we summarize this you see the amount of patients being in 10 different kinds of publications. If you use MLA as a cutoff value, where the optimal cutoff value is close to the 2. And these are all patients compared with FFR based on the wire technology. You can see the area under curve as being 0.77, sensitivity 73, 71% for the specificity. MLD, lower cutoff value, even a somewhat higher area under curve, although this is statistical not difference. And the presented area stenosis, which is in my opinion always the most classical and the most logical to be that did perform less well, close to the 70% area stenosis, with some lower area under curve for this technology. Now that's just basic using either one image or 2 images if you use area stenosis. But if you really work on this technology, and you have seen this, if you have all the 3D slices of the OCT, you can easily calculate, of course, using the similar kind of heart flow modeling techniques, predict what the pressure drop established from different kinds of flow situations for this vessel could be, with a proximal reference area, an MLA in area in between, but also kind of multiple lesions sequencing. So if you just do the calculation that, and then Chen Young 2 has done that very nicely. The OFR 0.83 for this patient was published in 2019. Now, if you compare this MLA, which is again an area under curve of 0.8, and now with the newer version, with the OFR, with an area under curve of 93, you can see that anatomy in a very high resolution has a very high predictive value of what you have to do. Now I want to make back a bit the step, because what do we know from the FFR guided for the non-Coopered lesions? So this is a bit on where we look at Coopered lesions or your stable angina patients. This is going to discuss a bit with you that we have seen a lot of studies complete, Coopered, etc., on angio-guided procedures on non-Coopered lesions with complete revascularization. But if you look at the compare acute results which use FFR, they still had quite some events which were not identified by the FFR. So the FFR might not, in the ACS patients for the non-Coopered lesion, be superior to angio-guided. And I want to discuss that in some more slides. This is the other part of the seminar, looking at plaque vulnerability and plaque rupture, with Valentine Festor as one of the main authors. Looking at the OCT, you have seen that over the years, it can really nicely identify thin cap fibroatheromas. It can identify microphages in the plaque. It can identify these thrombus, like an erosion or on the calcium on top of it, and microchannels indicating neorevascularization. Also, all features of high-risk lesions. Now, if you looked at Cooper ruptured lesions, they were frequently lipid plaques, thin cap fibroatheromas with microchannels, eccentric plaque, and some positive remodeling were all predictors. Where are these thick paths identified? Usually pretty proximal in the vessel, between 10 and 30 millimeters, only in the right coronary artery. You know how long that is. There are some thick paths in the more distal vessel. It was very interesting to see if this can be even taken a step further versus only visual interpretation, but also with more artificial intelligence analysis over the OCT. Again, Chen Young 2, who's the main driver in these kind of things, he developed the thin cap fibroma and also a lipid to cap ratio based on the OCT. So you look again at the angle of the lipid area, the cap thickness, and then he came up with this calculation, the LCR. And the study aim of which presented in this year, 2001, on the PCR, to evaluate these OCT-derived parameters in predicting non-Coopered vessel-related MACE. They studied almost 700 patients, or close to 700 patients, 1,000 lesions. And again, we look at the cut-off values for MLA, being present, and you come up with the same sensitivity specificity. Now, if you look at their measurements of LCR and OFR, you can see how much better that is predicting than the MLA. And this is looking not only at FFR's comparison, but MACE events, non-corporate MACE events. You know that from several different early studies. How can we predict these other lesions? We cannot just do FFR, but we can also do OCT of your non-corporate lesions. So try to predict if they are going to be a problem. This is a bit similar to the prospect, combining several events. So LCR above 0.33 or OFR between 8.84, all in a single technology without any pressure wires. The hazard ratios, you can see how high they are, and they are really helping to identify what's happening in these kind of lesions. It's interesting. I just want to make one commercial slide that the companies are, of course, working on it. So in the current OCT algorithm from Abbott, using MLD, the morphology, and then the MAX, that will be in the later sessions of this morning. The morphology is currently mainly calcium. They can automatically detect that. But within the next few years, using artificial intelligence, also we are working that in our university hospital, to identify the lipid cores, the cap thickness, etc. So we expect that will be really, really nice in the short future. Let me look at the time. A few more minutes, then I think we can looking at flow reserve for obstructive lesions. A bit back to anatomy. Based on angiography, so can be on CT angiography and angioangiography. I wanted to share with you that these developments has been starting in 2013, 2014, different ways to work on that, published, and JACC Cardiovascular Interventions 2014, the relation between an FFR based on the QCR and the actual FFR. You can see that it's not perfect, but potentially useful. And I'm taking these steps very fastly because at this DCT just last month, Favor 3, China was presented. And look at that. They do that for with the same construction, 3D reconstruction of the vessel, use a frame count, and quantify a QFR based on angiography only, not using an OCT, but just using the angiography system. And what was really interesting too, they compared the QFR guided strategy with an angiography guided strategy, but typical for China, almost 4,000 patients in a very short time. And if you see that, they used sham procedure to really give the 5 to 10 minutes which is needed to do the QFR, give the patients headphones, give the staff no information for who will do the follow-up of the patients, if that was either QFR or angiography guided. Now, of course, similar to an invasive FFR and for a wire-based FFR, if you do that, you will see that quite some patients are finally not treated. That's in this slide, so it goes down. Actually treated in the QFR from 100%, I would say, so 16% reduction or 20% reduction. There are few patients which are also interesting. Initially, the operator thought that was not being significant and was now being hemodynamically relevant based on the QFR. So some patients, more patients are deferred, and a few patients are getting an additional treatment. And I will go to the results. The primary endpoint, which included the procedure. So if you do less stenting, you will have less side vent occlusions, less thrombus, etc. Of course, initially already have some differences. But this was the primary endpoint, with a p-value really being true, significant, and a hazard ratio of 0.65. And it was now published in the Lancet simultaneously. What you see on the second image, which is just overlapping a bit too much, but these are excluding the periprocedural MIs, which was this initially trend. So that's kind of quite a landmark, but this is not that relevant. And even here you see the reduction from endpoints, including typical MACE infarction re-interventions, etc., from 4.8 to 3.1, which is a hazard ratio of 0.6, again, with 12 months follow-up. So it seems to be that QFR is really possible. I demonstrated you the OFR earlier, and I just want to update you, or this is publication from 2020, comparing both technologies, the OFR and the QFR compared to an FFR wire, invasive wire. A correlation was better for the OFR versus the QFR, which is, of course, a bit less resolution versus the OCT. And that will, I think, we will see that in the future. Calcium, I probably better skip that for the moment of time. I just wanted to follow up you on my initial patient, presented me 50-year-old patients, thrombus in the proximal LED. In this case, I think this is an MLA which is pretty large, and this is all thrombus. We didn't see any eruption based on the erosion study 2016. I now skip the erosion 2, which is presented at TCT, but similar results. We treated the patients with 2B3A inhibitors for a few days, small CK, follow-up OCT, MLA increased 7.4, no thrombus remaining, patient 50 years old, not a permanent metallic implant for the rest of his life. So in summary, I think there's a lot possible with the anatomical assessments. The QFR is on its way to match wire-based technologies. High-resolution anatomical imaging will help you to identify plaque erosion, calcified nodules, plaque ruptures with non-obstructive lesions, spontaneous dissections, and then also in the non-culprit lesions. It might be even better than FFR to identify high-risk lesions with TIGFA, small MLA, high plaque burdens. The high-resolution OCT provides best information derived flow reserve, the OFR, and that might be more patients which have less high-risk plaque characteristics, but to identify the patients where imaging is important, or identifying of the true ischemic lesions, which needs to be treated with a PCI, or could be treated to resolve the symptoms of the patients. So I'd better stop now because I can give some other time for the next presenter.
Thank you very much, Professor Robert.